Okay. The next category of drugs that you need to be aware of for heart failure include loop diuretics. And so if you ever had any clinical experience, you may have heard of a patient taking Lasix. That's the brand name drug for furosemide. And so these drugs are very useful for removing water from the system. And so the prototype drug, or the oldest one in this category, is Lasix, and that's furosemide. It's on every hospital formulary, and it's the cheapest out of all of them. So mechanistically, it's going to inhibit the sodium-potassium 2-chloride transporter, and that's within the thick ascending pathway. And that's going to produce dramatic water loss, and it's also going to inhibit sodium reabsorption. And so, salt follows water. And so if you get rid of water, you're also going to get rid of salt as well. It is the most potent class of diuretics, and it's really the best diuretic out there in terms of its ability to remove sodium. The rationale for this drug is that patients that have heart failure may also exhibit fluid retention, and so sometimes we'll call this volume overload. These drugs will combat the physiological outcomes to volume overload, and so these drugs will reduce end diastolic volume, and they'll also slightly increase stroke volume and cardiac output. And so we'll use these drugs again and again throughout the curriculum in specific examples of volume overload. So heart failure is one of them, ascites is another. Situations where you want to reduce potassium secretion, so there's also a potassium effect. Also enhanced calcium and magnesium secretion, and useful for hypercalcemia. And so lots of clinical indications for loop diuretics. This isn't all of them, but this is most of them. And so there's going to be several instances throughout the curriculum where these drugs are going to be used again and again. So in terms of pharmacodynamics, furosemide and others in this category enhance renal blood flow, and they do that through induction of the COX-2 expression, which is going to essentially increase prostaglandin synthesis. Okay, and so we'll talk more about this in terms of the kidney unit, which is coming up next, and you'll be able to see the consequences of enhanced renal blood flow. And so in the patient, in terms of low cardiac output or systolic heart failure, these drugs are kind of a life-saving aid to the volume overload that can manifest itself. These drugs are rapidly absorbed. They're eliminated by the glomerular filtration within the tubular secretion, and mechanistically they act at the luminal side, okay, of the tubule. And the diuretic activity is really going to be dependent upon the secretion of this drug at the proximal tubule. And so understand too that certain drugs, like the NSAID, probenecid, remember NSAIDs are COX inhibitors, they're going to reduce the secretion by the proximal tubule. So patients that are taking high amounts of COX inhibitors likely will not benefit from loop diuretics such as furosemide. It'll be a reduced efficacy for them. Also, patients with renal insufficiency, as well as decompensated heart failure, which we'll define later, may require higher doses. And so, the overall health of the kidney is going to determine how effective these drugs are at actually promoting diuresis, or actually, relieving water from the system. So indications for loop diuretics, there are several: heart failure, acute pulmonary edema. You can force diuresis in the context of a drug overdose. If the patient has hypercalcemia, you can enhance calcium excretion. If the patient has hyperkalemia, you can enhance potassium secretion when you administer this with saline. And so lots of clinical indications for loop diuretics outside of the context of heart failure. That's not to say that these drugs are without any kind of adverse effects. The adverse effects and toxicity really come from the main therapeutic targets, but in excess. And so, mechanistically, we can see enhanced potassium and proton excretion. However, in the context of toxicity, you can promote hypokalemia and you can promote metabolic alkalosis if these two processes occur. Loop diuretics have the ability to compete with the acid secretion transporter, which we'll expand more about in the kidney unit, which is coming up next. And the effect observed would be excess uric acid. There could also be an enhanced excretion of magnesium and calcium, setting the patient up for potentially cardiac arrhythmias. This really comes about when the patients who were at one point volume overloaded have a volume contraction and are dehydrated. And so think of a patient with heart failure who's maintained on a loop diuretic for maybe several years, gets a gastroenterovirus or some type of an infection that has lots of diarrhea, and so their physiology abruptly changes and they become low volume, and they continue to take the normal dose of furosemide or the normal dose of Lasix. This can actually induce some cardiac arrhythmias, and that's clinically relevant. There can be some hearing loss or impairments that's reversible. That's usually seen with ethylcrinic acid, not so much with the other ones. And then remember we talked about sulfonamides in the other lecture. Some of these drugs, particularly ethylcrinic acid, have a sulfonamide or sulfur-containing moiety structure within their chemical structure. And so patients that are allergic to sulfonamides may exhibit hypersensitivity reactions to this class. And so those are kind of the main adverse effects and toxicities that we associate with loop diuretics. But for the most part, loop diuretics are relatively well tolerated and don't really exhibit dramatic side effects and toxicities unless there's major changes in baseline physiology. Okay. Of course, there are contraindications. As I said before, if there's severe sodium loss or there's volume depletion in the context of maybe like a GI infection, you'd want to avoid or discontinue the use of the loop diuretic. And then the hypersensitivity to sulfonamides would be a contraindication. You wouldn't want to give a patient these loop diuretics because of the structure. This is just kind of for some background information. I expect you to come back to this table when you're reviewing for STEP and board preparation questions, but there are several well-known and well-characterized drug-drug interactions. At this point, we haven't talked about any of these other drugs, but so you will learn about them in the very near future. So that summarizes the information you need to know for loop diuretics, and we will continue on with the other classes of drugs for heart failure.